Chapter 6, Answering Clinical Questions 1, Searching for and Assessing the Evidence. Chapter 5 reviewed various research methods that generate data. This chapter deals with searching for, evaluating, and using research data to help answer clinical questions. Take the example of an obese but otherwise healthy 50-year-old white American woman with hyperlipidemia. We might want to know what the best treatment is for her. Before looking for studies that might provide an answer, the first task is to clarify the question, which needs to be broken down into 4 components, commonly summarized by the term PICO. P. Who are the participants? Patients, population. It is unlikely that a study has been done on patients who are exactly like the one we are interested in. If we limit our questions to such patients, we will reduce or even eliminate the chance of finding relevant evidence. If we broaden it, we risk finding evidence that is invalid for our patient. In this case, we might settle for studies on otherwise healthy female patients with hyperlipidemia, leaving aside for the time being factors such as age, race, obesity, or nationality. I. What is the intervention? The intervention in this case may be a drug, a diet, or an exercise or an educational program. There is unlikely to be a single study of all of these, so we might choose a narrower question such as, is drug treatment for hyperlipidemia beneficial? C. What is the comparison? The comparison may be no treatment or a placebo, or it might be another drug, a diet, or an exercise program. O. What is the outcome? Asking, is drug treatment beneficial, is clearly too vague. It is crucial to know whether treatments produce outcomes of clear clinical importance, such as how a patient feels, functions, or survives. Studies that provide this are called POEMs, POEMs, patient-oriented evidence that matters. For example, POEMs for hyperlipidemia treatments would examine outcomes such as death or disability due to heart attack or stroke. The cost of the treatment or of the disease to the patient is also a patient-oriented outcome. In contrast, studies that measure only physiologic outcomes or biomarkers such as cholesterol levels, intimal medial thickness, or blood pressure are termed DOEs, disease-oriented evidence. These physiologic outcomes are surrogate outcomes, or more properly, surrogate endpoints, as they are substituents for actual outcomes. As it is much easier, cheaper, and quicker to obtain DOEs than POEMs, reliance on surrogate endpoints is very common, particularly for treatments for chronic diseases. Indeed, many treatments are approved on the basis of surrogate endpoint data only. It is often assumed that if a treatment improves a surrogate endpoint, it is beneficial, but this is not necessarily the case. Many treatments that improve surrogate endpoints lack evidence that they improve actual outcomes, and several have been found to actually worsen clinical outcomes, either before or after coming into widespread clinical use. For example, despite producing dramatic improvements in cholesterol profiles in phase 2 trials, the drug torcetrapib was abandoned in 2007 after an estimated $800 million had been spent on its development following 15,000 patient phase 3 trial, which shows increased rates of death, heart failure, angina, and revascularization procedures in patients receiving the drug, done by the study by Barter and Company in 2007. Following the PICO process, the refined question might now be, do drugs prevent or delay death or disability in otherwise healthy women with hyperlipidemia? At this point, we might simply ask a senior physician or a respected expert in the field. However, the principle of evidence-based medicine, EBM, is the actual evidence rather than opinion, must be the primary scientific basis for making clinical decisions. Different types of evidence are judged to be of different value. Hierarchy of evidence. The hierarchy of evidence, seen in Table 6.1, shows which kind of information are the most valuable. The best evidence is provided by evidence synthesis, with systemic reviews at the highest level, followed by meta-analyses. Next come experimental data from randomized controlled trials, RCTs, and then non-randomized controlled trials, followed in turn by non-experimental or observational data from cohort studies, case control studies, case series studies, and case reports. This hierarchy is not absolute. For example, a meta-analysis of well-conducted randomized trials may provide better evidence than a systemic review of poorly conducted non-randomized trials, and within each level there may be studies of high or poor quality. Note that the very lowest level comprises expert opinion based only on anecdote, physiologic, or in vitro data of first principles, none of which strictly constitute evidence per se. Systematic reviews. Unlike traditional literature review, which typically reviews only the published studies that the authors judge to be most important, systematic reviews are objective, with the goal of enabling clinical decisions to be made on the basis of all the good quality studies that have been done. In a bona fide systemic review, there is a defined clinical question as above, and the studies reviewed meet specific inclusion and exclusion criteria, typically using the term PICOs, which comprises the PICO parameters with the addition of S, the type of study design. The literature is searched in a painstaking way to include all relevant studies, typically including foreign language studies, thus avoiding language bias, the so-called gray literature, including unpublished studies. Published studies are not representative of all the studies on a particular topic for several reasons, including the fact that negative studies which fail to find statistical significance are less likely to be published than positive studies, resulting in publication bias. Negative or unpublished studies are also likely to take longer to be reported, resulting in a time lag bias, and they are likely to be less widely reported, cited, reviewed, or publicized, resulting in reporting, citation, and dissemination biases. The gray literature may include studies in trial registries such as clinicaltrials.gov with over 100,000 trials. Registration is mandatory for trials in the United States or in the files of pharmaceutical companies, known researchers in the area, and study sponsors, and also theses and studies reported only as conference presentations. Note that standard databases such as Medline, although important, include only published studies. A manual hand search of journals likely to have published relevant studies for studies that may have been miscoded or mislabeled and therefore do not appear correctly in electronic search results. This may also reveal data that has been published more than once, which causes multiple publication bias. Studies identified in the citations lists of studies otherwise identified. Relevant studies are identified, verified as meeting the inclusion and exclusion criteria, and their validity and handling of missing data are then evaluated, ideally by 2 or more independent reviewers. A final list of acceptable studies is thus obtained, and their data is then abstracted to fit a uniform template, enabling a quantitative analysis to be performed. Meta-analysis. Meta-analysis is the quantitative analysis of the results of a systemic review. Its validity depends on the quality of review and the unyielding studies. Advantages of analyzing the combined results of multiple studies include the following. With an increased total sample size, the power of the analysis is increased. So type 2 errors in which trials fail to show effects that are typically present are less likely, and the precision of the estimate of any effects is increased. If multiple studies show significant results, type 1 errors are less likely using a p of 0.05. The probability of one study making a type 1 error is 0.05. The probability of multiple studies all making errors at this level is dramatically lower. Multiple studies are likely to have been done in different geographical areas, with patients drawn from different populations, therefore increasing the generalizability of the results. The extent to which a systemic review is influenced by publication and other biases is often assessed by means of a funnel plot. A funnel plot displays the effect size plotted against a sample size. Normally, there will be more variability in the results of smaller studies than larger studies, and so this plot should look like an inverted funnel, with the larger study results clustering around the overall mean effect more closely than do the results of the smaller studies. If the small studies are simply producing less precise results than the larger ones as expected, their results should be symmetrically spread around the mean, as shown in Figure 6.1. If this is not the case, as shown in Figure 6.2, where the distribution of results of smaller studies is asymmetrical, it suggests that some smaller studies that showed unfavorable results may be missing from the analysis because of various biases. A single estimate of the results of all the studies in a systematic review is obtained by pooling their results. Sometimes the individual study results are weighted, altering the influence they have on the overall results according to the precision of their estimate. The result is a measure of effect size, typically the risk ratio, also known as relative risk, discussed further in Chapter 8, which is the ratio of the frequency of events in the intervention group versus the control group. For example, the frequency of heart attacks in a group of patients given a cholesterol lowering drug versus the frequency of heart attacks in a group of patients given a placebo. So a ratio of 1 would reflect no difference. A ratio of 2 would reflect a doubling of the risk with the drug, and a ratio of 0.5 would reflect a halving of the risk. However, this measure may be misleading if the studies in the systemic review are too different from each other, such as in patient types, the intervention studied, or the outcome measures, to be legitimately combinable. Meta-analysis use tests of heterogeneity to test the null hypothesis that the underlying effects seen in the studies are similar and that any difference in the effects is due to chance. If the null hypothesis is rejected, then it is concluded that there are significant differences between the studies that make a single pooled outcome unlikely to be valid. If this seems to be the case, a sensitivity analysis may be done in which various categories of studies, for example, unpublished studies, apparently low quality studies, commercially sponsored studies, are excluded to see whether the overall conclusions are robust or whether they are sensitive to the inclusion of these groups of studies. For example, if the exclusion of studies sponsored by drug companies changes the conclusion of a meta-analysis, the validity of these studies would be open to question. Results of meta-analyses are commonly presented as forest plots, which allow the results to be seen at a glance, with ready identification of outliers. Figure 6.3 is an example of a forest plot produced by a meta-analysis of studies of the effects of statin drugs on the risk of developing ventricular arrhythmias in patients with cardiomyopathy. As shown, each individual study's result, its point estimate, is plotted separately. The size of the rectangle representing the study is proportional to its sample size. The horizontal line on either side of the result shows the 95% confidence interval surrounding the point estimate. The location of the result shows whether it favors the intervention, the statin drug, or not. The vertical solid line is a line of no effect, where there is no difference between the intervention and the placebo, that is, a risk ratio of 1. The overall pooled result of the meta-analysis is shown by a diamond. Its center shows the overall aggregate effect, and its lateral corners show the associated 95% confidence interval. If these corners do not cross unity, the line of no effect, then there is an overall statistically significant effect, as the ratio of the frequency of events in the intervention group versus the control group is not 1, at a 95% or higher level of confidence, as shown in the figure. Here's a figure 6.3 forest plot showing the effects of statin drugs on the development of ventricular arrhythmias in patients with cardiomyopathy. Different types of studies, statins versus not favoring statins. And this is the confidence interval you have on how likely it is to develop ventricular arrhythmias. Hmm. Searching for evidence. In searching for evidence to answer a clinical question, the easiest way to find high quality evidence is by searching for systemic reviews and meta analyses, particularly using resources devoted to EBM, such as the Cochrane database of systemic reviews at www.cochrane.org, TRIP database, DARE, Bandolier, and American Colleges of Physicians Journal Club. However, for many clinical questions, evidence syntheses may not be available, and the clinician will need to review the individual studies in the primary literature. Searching for individual studies. Several tools are available for searching the primary literature, the best known being the PubMed search interface for the Medline database, which currently holds over 21 million publications. No matter what search tool is used, similar principles apply. As with systemic reviews, searching the primary literature also uses the PICOS concept. Each element of PICOS can be framed narrowly or broadly, and the S component, study design of the search, will depend on the kind of question being asked. Clinical questions typically fall into one of 5 categories: questions about treatment, harm, differential diagnoses, diagnostic tests, and prognosis. Questions about treatments are best answered by RCTs, such as what is the best treatment for hyperlipidemia? Questions about harm, such as does a high-fat diet increase the risk of cardiac events, would ideally be answered by RCTs, but for ethical and practical reasons are often addressed by observational studies, such as cohort and case control studies. Questions about differential diagnoses, such as what is the cause of this patient's chest pain, will require studies in which patients with similar signs and/or symptoms undergo different tests, which may include physical examination and a detailed history, and are then followed until the true etiology of their syndrome becomes apparent. Questions about diagnostic tests. What is the best test for the diagnosis of chest pain? Require studies in which the test in question is compared with the results of a gold standard criterion for the diagnosis in question. This will be reviewed in Chapter 7. Questions about prognosis. How long is it likely to be before this patient with hyperlipidemia has a cardiac event? These questions involve following patients with a particular diagnosis or undergoing a particular treatment for an extended time with a form of cohort studies. Once the question has been clarified, search terms are defined by using tools such as medical subject headings vocabulary. This is a hierarchical thesaurus of over 25,000 defined medical terms. Each article in PubMed has been assigned descriptors from the medical subject headings vocabulary, and by using appropriate medical subject, heading, search terms, and more accurate results are obtained. Broadening the search by including synonyms, for example, hyperlipidemia and hypercholesterolemia, abbreviation, for example, RCTs, and different spellings such as anemia and anemia. The MESH thesaurus helps with this, as entering a search term in MESH will show its symptoms as well as what higher level terms it is a subset of and what subterms lie under it when it is exploded. Limiting the search, such as to RCTs on humans only, to certain publication dates, types of article, or specific ages, either by tools that are built into the search engine or by using Boolean operators such as and, or, and not. By doing this, typically in a series of iterations, search results can be drastically narrowed down or expanded to produce a usable number of citations that are appropriate for the question. In PubMed, the clinical queries tools also helps accomplish this in a simplified but faster way. But note that the preset filter it provides for systematic reviews uses this term in a very broad way that is not consistent with its usual definition. Appraising studies. Once a research result has been obtained, whether of evidence syntheses or primary studies, it must be appraised. Potential flaws in systemic reviews and meta analysis have been discussed above. Potential flaws in primary studies, biases, confounders, lack of representativeness, loss to follow up, problems of internal validity, external validity, and generalizability have been dealt with in Chapter 5, and those involved in hypothesis testing, for example, type 1 and 2 errors, lack of power, lack of clinical as opposed to statistical significance, inappropriate subgroup analysis, were reviewed in Chapter 3. Application to patient care. No matter what kind of research has been used to answer a clinical question, the results of even the best conducted and most valid study will not be of practical use in patient care unless the treatment or intervention is actually available. And it suggests real world effectiveness and cost effectiveness on the patient oriented outcomes. It shows a causal relationship between the independent variable, the treatment, intervention, test, etc., and the dependent variable, effectiveness versus efficacy. Clinical trials are likely to be performed in near ideal conditions with careful attention to patient compliance and adherence to treatment protocols, better availability of support staff, little or no or even negative cost to the patient, and less time pressure than in regular clinical practice. The ability of a treatment to produce results under these ideal conditions is its efficacy. Can it work? Which is likely to be higher than its effectiveness, its ability to produce results in real clinical use, where time and resources are likely to be more limited. Does it work in the real world? For example, the effectiveness of a vaccination program for a large rural population in a developing country is likely to be rather lower than its efficacy in clinical trials performed in an urban academic medical center. For the clinician, the difference between efficacy and effectiveness amounts to asking whether the benefits seen in a clinical trial are likely to be reproducible for the patient you have in front of you. The PICO parameters again help. Are the patients in the clinical trial similar to your patient? Elderly patients, for example, are typically underrepresented in clinical trials, as are patients with multiple comorbidities or on multiple other medications. Is the intervention the same? Perhaps the study drug used a different dose or a form that is similar but not identical to the one available in regular practice for various reasons, such as unavailability, formulary restrictions, costs, etc. What is the comparator? In clinical practice, there is typically a choice of several treatments, but there may be few or no trials of one treatment against another, so called head to head or active comparator trials, rather than trials of treatments against a placebo. What is the outcome? Poem data is far preferable to DOE data, but may not exist. Cost effectiveness. If an intervention is effective, a critical question is whether it is cost effective. Is it worth it? As medical resources are not unlimited, a new treatment that is cheaper and more effective than an existing one is clearly cost effective. But if a new treatment is more expensive and more effective, or cheaper and less effective, questions of cost effectiveness arise and will inevitably involve value judgments. A treatment that is just cost effective does not necessarily save money, and a treatment that is cheaper is not necessarily cost effective. Cost effectiveness is very sensitive to the cost of treatment, which will vary considerably in different places. For example, a coronary bypass is likely to be much cheaper in India than in the United States. And at different times, a drug may become dramatically cheaper once it goes off patent and generic formulations are available. A treatment that is highly efficacious in trials will be ineffective in practice if patients or healthcare systems are unable to afford it. More formal aspects of cost effectiveness will be discussed later, and the related concepts of number needed to treat will also be discussed. Causality. Although randomized controlled clinical trials are the gold standard for demonstrating causality, a single RCT is unlikely to be taken as conclusive, especially when applying the PICO questions above. Clinicians are frequently required to use their best judgment about questions for which there are no good evidence syntheses, or only inadequate or inconsistent RCT data, only DOE but no poems, or only correlational or observational data. This is especially true for questions about diet or lifestyle factors or the use of complementary treatments, for example, supplements, herbal medicines, acupuncture, hypnosis, chiropractic. Evaluating a possible causal relationship between independent and dependent variables involves considering the strength of the association, such as between use of a treatment and reduction in symptoms, the degree to which the findings have been replicated consistently in different settings, the specificity of the association, such as between exposure to a risk and the resulting symptoms, temporal relationships. Is it clear that the proposed cause, risk factor, or treatment came before the outcome, the disease or improvement? If, tempor- if temporality is unclear, it is possible that apparent causation may in fact be reverse causation, in which the dependent variable is actually the independent variable and vice versa. For example, studies in many developing countries have found that breastfed infants are at greater risk for growth retardation, which suggests that breastfeeding may cause poor growth, but there is evidence that the reverse is actually the case, and that mothers are in fact more likely to breastfeed a child who they perceive as growing poorly. Biological gradients. Is there a dose response relationship such that as exposure increases, the outcome also changes? For example, is there a relationship between the lifetime number of cigarettes smoked and the risk of lung cancer, or between the dose of a cholesterol medication and the risk of myocardial infarction, or between the number of chiropractic adjustment and back pain? Plausibility. Does the relationship fit in with our common sense knowledge of how the world works? Coherence. Do the findings fit in with other data or theoretical models to make a coherent picture? Analogies. We are more ready to accept causal explanations that are similar to other explanations that we already accept. For example, when you take a drug to reduce the cholesterol in your arteries, the effect is like unblocking pipes. Referring patients to appropriate information resources. Answers to clinical questions are of course sought by patients as well as doctors, and the majority of adults in the United States at least have sought health information online. Medical information online is almost limitless, and much of it is inaccurate if not misleading, whether for commercial or other reasons. Patients can be advised that the following are generally recognized to be reliable sources of information: Medline Plus, the National Library of Medicine's website for consumer health information, Centers for Disease Control and Prevention, particularly for current information on travelers' health worldwide, FamilyDoctor.org, produced by the American Academy of Family Physicians, Cancer.gov, the official website of the National Cancer Institute, Health Finder, providing health information from the U.S. Department of Health and Human Services. Patients performing their own searches for medical information online should be advised to know the sponsor of the website, whether a government agency, professional organization, nonprofit group, commercial organization, or individual patient. Each of these may have their own agenda. Look at the source of the information. Are the authors listed? And what are their credentials? Are references to legitimate publications cited? Be skeptical, especially of claims of breakthroughs and cures, secret ingredients, or what they don't want you to know. Sites selling alternative treatments, self published books, or unconventional tests, and sites where editorial content and advertising are not clearly distinguished should be treated with suspicion. Understand that the case histories, anecdotes, testimonial, and unsupported expert opinion are all considered the lowest quality of evidence. Realize that medical information is constantly changing and that a source that does not list the date on which it was reproduced is likely to be out of date. Look for a current certification by the Health on the Net Foundation, a nonprofit organization that certifies that websites comply with a number of ethical principles. Certified websites show an icon that links back to the Health on the Net website, showing details of the certification.